Hi everyone, welcome back to LipidCurious, an educational platform focused on simplifying lipid management for clinicians. I'm your host, Dr. Vishnupriya Pulipati, a board-certified endocrinologist and lipidologist. In part 1 of this series, we discussed how to approach ASCVD risk before opening a risk calculator. Today, we are building on that foundation. If you haven't listened to part 1 yet, I strongly recommend doing that first so this episode will make much more sense. In this episode, let's focus on 1. How to approach primary prevention, 2. How to utilize ASCVD risk calculators, risk enhancers, and coronary calcium score, 3. How to apply what we learned so far in clinical practice. Alright, let's get started. We started thinking about ASCVD risk stratification with 3 important questions. So first question, do they already have an atherosclerotic disease of the heart, brain or blood vessels? 2. Is their LDL more than 190 mg per deciliter? 3. Do they have any type of diabetes mellitus? If the answer is yes to any of these, we are already thinking about treatment. If the answer is no to all of these, then we are thinking about primary prevention. So how to approach primary prevention? I recommend to start with looking at age. In children 0 to 19 years of age, we consider a high-intensity statin only if they have familial hypercholesterolemia. In young adults between the ages of 20 to 39, we consider a statin if the LDL is more than 160 and there's a family history of premature heart disease. If this group is needing a statin, you can consider using the lifetime ASCVD risk calculation to guide the intensity of treatment. Lifetime ASCVD risk more than or equal to 39% is considered high risk. Next, middle-aged individuals 40 to 75 years is where we use risk calculators, risk enhancers, and coronary calcium scoring, which we'll cover in just a bit. In older adults more than 75 years of age, we individualize the treatment. Consider initiating moderate intensity statin if the LDL is between 70 to 189. In select patients between the ages of 75 to 80, coronary calcium scoring may help when the decision to start or continue statin is uncertain. And we consider discontinuing statin when risks outweigh the benefits, such as situations of frailty, functional decline, or limited life expectancy. Let's talk about choosing an ASCVD risk calculator. For adults between the age of 40 to 75 years, risk calculators can help guide treatment decisions. There are many tools available, but today we're going to discuss about 2 of them: the PREVENT calculator and the pooled cohort equation. The PREVENT calculator is a newer tool available. It estimates 10-year and 30-year risk for total cardiovascular disease, atherosclerotic cardiovascular disease, and heart failure. If you see the calculator, you can actually toggle between these options so you can get risk estimate for each of these entities. This information was derived from more than 6.5 million United States adults, and it is appropriate to use in adults between the age of 30 to 79 without a known cardiovascular disease. The recommendation is not to use the PREVENT calculator if an individual has severe subclinical disease such as EF less than 40%, calcium score more than 300, or end-stage renal disease or limited life expectancy. What makes PREVENT different and awesomer? They took out race as a variable because they identified race is not a cause of disease. Then they included important cardiometabolic markers such as eGFR, albumin-creatinine ratio, HbA1c, and interestingly, they also included a social factor with a zip code, which estimates the environmental influence on cardiovascular disease. This calculator is more comprehensive, better calibrated for diverse populations. So why are we not using it every day and more often? Because we don't have clear guidance on what to do with the results of this calculator. For now, PREVENT calculator is best used to support the clinician-patient decisions. Next up is pooled cohort equation, the calculator we use more commonly in our clinical practice. This estimates the risk of myocardial infarction, stroke, or cardiovascular death. It is validated for African American and non-Hispanic white men and women. Some of the limitations of this calculator is it is not applicable in individuals with atrial fibrillation or above the age of 79 because these patients were excluded. It underestimates risk in American Indians, South Asians, and Puerto Rican ethnicities, and it overestimates risk in East Asians and Mexican American population. When we use the pooled cohort equation, we get lifetime ASCVD risk for the ages 20 to 59, where more than 39% is considered high risk. And there's also a 10-year ASCVD risk estimate, which comes up for the ages 40 to 79. Now, when we get the 10-year ASCVD risk score, I remember 3 numbers. It's very easy, just 3 numbers: 5, 7.5, and 20. That's all you need to remember. Less than 5 is low risk. 5 to 7.5 is borderline risk. 7.5 to 20 is intermediate risk. And more than 20 is high risk. If someone is low risk, we don't need to treat. We just encourage lifestyle changes. If someone is high risk, we offer high intensity statin. The gray zone is borderline and intermediate risk. This is where risk enhancers matter. If an individual is borderline risk with the risk enhancer, we start a conversation about moderate intensity statin. If an individual is intermediate risk with the risk enhancer, they're very close to high risk, right? So we favor starting moderate intensity statin. And in this particular group, if the patient is hesitant to consider a statin, we utilize the coronary calcium score to refine risk further. Okay, now let's look at ASCVD risk enhancers, and I want to give you an idea about how I remember them. Instead of memorizing a big table, I think about ASCVD risk enhancers during routine history taking: age, comorbidities, pregnancy history, family background, habits, and key labs. If you ask these questions consistently, you don't need a big table to remember. And electronic medical record dot phrases also help if that is your preference. But what helps more is repetition with these concepts. When ASCVD risk estimate is borderline or intermediate, I run a quick mental checklist. And if it's easier for you, you're a person who likes mnemonics, you can remember head to labs. H, history. History of hypertension, chronic kidney disease, metabolic syndromes, PCOS, chronic inflammatory conditions, preeclampsia or premature menopause. E, ethnicity and family. Family history of premature ASCVD or South Asian ancestry. A, age more than 65. D, daily habits such as smoking. L, lipid panel. Any abnormal lipids such as high LDL, high triglyceride, low HDL. A, advanced markers such as lipoprotein A, ApoB, HSCRP being abnormal. B is blood flow, ABI or ankle brachial index being abnormal. And S is silent diseases such as metabolic liver diseases, not always listed in the guidelines, but I find that clinically important to include among the risk enhancers. So if I hear yes to any of these, again, any of these heads to labs mnemonic which I just told you about, risk enhancers are present, and that helps us with decision making. Next up is coronary calcium score or CAC score. This is usually used as a tiebreaker in intermediate risk individuals. If a patient is more than 40 years, has borderline or intermediate ASCVD risk, and the decision to start therapy is unclear or the patient is hesitant, coronary calcium scoring helps. Be mindful, it has limited utility in patients who are active smokers, individuals with diabetes mellitus, strong family history of premature heart disease, chronic inflammatory conditions, and patients already on a statin. The calcium score is reflecting calcified plaque only. It does not show the total soft plaques or atherosclerotic burden. So, for example, statins can show increased calcium score density because they're stabilizing the plaque, but they are still reducing the cardiovascular events. And in reverse, calcium score 0 doesn't mean zero risk, especially in individuals with higher risk biology. Let's talk about interpreting the calcium score. Calcium score 0 without any caveats we just spoke about, then you don't need to give treatment. We can repeat the calcium score in 5 to 10 years. If the calcium score is between 1 to 99, we favor statin therapy. If they choose against therapy, we can repeat it in 3 to 5 years. Calcium score more than 100 or 75th percentile, high-intensity statin is appropriate. Some societies also recommend low-dose aspirin depending on the bleeding risk. Okay, so far we spoke about how to approach primary prevention starting with age. We spoke about ASCVD risk calculators available. We spoke about ASCVD risk enhancers and how to remember them, and coronary calcium score. Okay, let's put it all together through two cases. Case 1. A 42-year-old African-American woman presents for wellness visit. She has a history of hypertension on amlodipine, smokes half a packet of cigarettes, BMI is 24, blood pressure 140 by 90 mmHg, fasting blood test shows eGFR 52, HDL 45, triglyceride 200, and LDL-C 135. So all of them were abnormal. I know, there are a lot of data points here, right? Don't get distracted. Let's stick to our framework. Okay, let's get started. Do they already have a heart attack, stroke, or blood vessel disease? No. Is the LDL more than 190? No. Do they have diabetes mellitus? No. Okay, we have come to the land of primary prevention. What is their age? They are 42. So, 40 to 75 years of age. We can use the pooled cohort equation calculator. We did the calculator and we got a number of 9.5. Remember, 5, 7.5 and 20. So this patient lies between 7.5 and 20. That is intermediate risk. Does she have any risk enhancers? Yeah, she has hypertension, she's an active nicotine user, she has low GFR and abnormal lipid panel. So we encourage taking a moderate intensity statin. Patient feels, you know what, I feel well, I'm not really sure if I want a statin, then we can offer a coronary calcium score. Let's say she went to the coronary calcium score and it came back as 120. That tips the scale, right? So now we recommend high intensity statin because the calcium score is more than 100. She agrees, everyone is happy, yay, right? See, you took less than a few minutes for that decision making. Next, let's take up a little more challenging case now. I want to show how we can navigate literature gaps. Okay? A 57-year-old South Asian man presents for a wellness exam. Non-smoker, he has a history of atrial fibrillation on anticoagulation, hypertension on thiazide diuretic, mild bilateral carotid stenosis, history of COPD not requiring oxygen, pre-diabetes, BMI is 38. Blood pressure 135 by 80 mmHg, HDL-C 35, LDL-C 142, and lives in Oklahoma. Okay, again, don't get distracted with all that data points. Let's stick to our framework. Do they already have a heart attack, stroke, or blood vessel disease? No. Is their LDL more than 190 mg per deciliter? No. Do they have diabetes mellitus? They have pre-diabetes, but not diabetes mellitus, so technically, no. All right, we have come to the land of primary prevention. What is their age? They're 57. Okay, let's grab the calculator, right? No. Why? Atrial fibrillation was excluded in pooled cohort equation, remember? So what do we do next for this patient? Well, we don't give up. In these situations, decisions I believe are driven by patient preference, clinician's prevention philosophy, and access to therapy. If the patient is proactive and access isn't a barrier, my own prevention mindset is I favor early LDL-C lowering. My mentors through my lipidology journey have consistently reinforced that lower LDL-C for longer is better. So when I see a meaningful ASCVD risk factor, my default is to think treatment. So now there are a couple of ways I might approach this case. First, I use the prevent calculator to frame the conversation. So I might talk to the patient like, hey, you have a 9% risk of a cardiovascular event in the next 10 years, 35% risk in 30 years from now. You have multiple risk factors such as South Asian ethnicity, you have abnormal cholesterol panel, we have excess weight, high blood pressure, and pre-diabetes. So I would like to offer you at least a low to moderate intensity statin for cardiovascular disease prevention. Second, I can also consider offering a coronary calcium scoring. And if the coronary calcium scoring is more than 100, I might even consider offering a high intensity statin. Okay, so these are the take home points of this talk. 1. Start with a consistent framework. Rule out ASCVD, LDL more than 190, and diabetes mellitus, then approach primary prevention by age. 2. For ages 40 to 75, which is middle-aged, use pooled cohort equation to estimate ASCVD risk and assist treatment decisions. Among individuals with borderline or intermediate risk, you can additionally use risk enhancers and calcium scoring to refine the cardiovascular risk. 3. Earlier LDL-C lowering for longer time matters. All right, folks, here's my challenge for you. For the next 2 weeks, with every patient you see with a lipid panel, practice the framework we discussed today. I'll see you back in 2 weeks for the final part of this series. In part 3, we're going to add the cherry on the top. We're going to talk about what are the numbers to target and which therapies to use. I'm really excited about that because that helps put all these concepts together in one good nugget. With the next episode, I'll also include a single easy-to-read visual that pulls this entire framework together for you. Before I sign off, a quick note. This podcast is intended for educational purposes for clinicians and healthcare professionals. It does not provide medical advice, establish a physician-patient relationship, or replace individualized clinical judgment. Thank you for tuning into Lipid Curious. If today's episode was helpful, consider sharing it with a colleague. You can always reach out to me at hello@lipidcurious.com. Be sure to follow or subscribe so you don't miss what's coming next. Until next time, stay curious and stay confident. Signing off, Dr. Pulipati.